get going. So welcome to the May edition of the CMR Journal Club. Today, it's a great pleasure for me to also formally introduce our new co-host, Dr. Nicole Seiberlich from Ann Arbor. So hi, Nicole. And Nicole will host the next one in June, or is it, I think it's end of May, right, Nicole?
It's May 31st, exactly.
May 31st, just because of ISMRM,
exactly.
It was rescheduled for a little bit. So the other announcement is that today, which rarely happens, but it sometimes happens, that there are personal emergencies, and Thomas Treibel, who wanted to present the other paper, had to cancel on short notice, and so he will not be able to present today, which means we have a little bit more time for this paper. So don't feel obliged to stretch it too far, Robin, and a warm welcome to you. I'm very happy that you can join. It's really fantastic. Your work is always really worthwhile looking at it in great detail. So it's great having you. Don't feel obliged to stretch it further. So if we finish early, that's fine. Usually it's about 10-15 minutes presentation of the paper, just going through the PDF, and then there will be opportunities to ask questions. As usual, feel free to post any questions into the chat, and we can ask them later. Or for those who then feel like it, it's okay to just unmute yourself and then ask the question personally. So without further ado, I would want to now focus the attention on this paper. It was published in JACC Imaging last year, and I found it very interesting because it uses an excellent data set, the UK Biobank, to answer a question that cannot be really answered by small samples. So it was a good use of a good data set for an important question. And the question is about the role and the impact and the relevance of mitral annular disjunction. And this is something that I remember way back when in my echo days, and also later in the MR days. That was always something we were a little bit puzzled about. And then we measured and we say, okay, should we report it or not? So there was, for the recent years, there was a lot of confusion of what it could mean. And this paper definitely helps in our understanding. It's called Mitral Annular Disjunction Assessed Using CMR Imaging, Insights from the UK Biobank Population Study. And today we have the first author, Dasa Zugwitz, and the senior author, Robin Nijveldt, who will present the paper. So Robin, very happy and pleased and honored to have you here. Take it from here.
Thank you very much. Thank you very much, Nicole and Matthias. It's a great honor to present this paper at your journal club, which is always fascinating to join. I think I can start with the first highlight, which is who is Dasa Zugwitz, who did the paper and did the calculations. And it started when she started her fellowship in Nijmegen in the Netherlands. And we had the same hobby, which was the mitral valve. And looking at the mitral valve, we had some huge mitral valve prolapse, but also with disjunction. And there was a lot of attention about disjunction and the risk of sudden cardiac death. And we saw that mitral annular disjunction happened quite a lot, but we didn't know if that was a coincidence or it was normal. And then we talked about it way longer. And then we tried to contact Stefan to see whether we could use the UK Biobank to see how normal annular disjunction was. And I think it kind of surprised both Dasa and me in the end how normal it was. That's something what we will discuss at the end of the paper. So I'll skip the abstract because we have more time. So we'll just do the whole paper. So as we all know, mitral annular disjunction, I will start with a picture just to show where you can measure it. This is a completely normal heart because it's Dasa's heart. And if you look at the 3-chamber view, the 4-chamber view, and the 2-chamber view, these are the sites where you can measure mitral annular disjunction if it happens there. So if you go, I don't know how we got the yellow thing on the, well, anyway, maybe you don't see it. If you look at this example, which is shows us a typical example of mitral annular disjunction, you see there's a gap between the left ventricular wall and the annulus of the mitral valve, and you can measure this. And in this case, it was 8 millimeters disjunction. So that's the thing that we are talking about. And usually we know that it's spread around a larger part of the annulus. So it's not confined to one particular part in the inferior wall or the anterior wall. It also happens, but normally you can see it spreads around a larger part of the annulus. In cardiac MRI, we have 3 long axis images. So we know from those sites if there is annular disjunction, but if you would do a whole swipe through the heart, you might see where it ends and where it stops if it's there. So a growing body of evidence has suggested that the disjunction, as I just told you, has a role in arrhythmic events, but a big problem of those studies is that those studies have pre-selected patient populations, and it's a real mixed bag of patients. So we don't know how the mitral annular disjunction happens in the real world. So that's why we studied the UK Biobank. The beauty of the UK Biobank, and I think that's the most important thing of looking at data which are retrospectively gathered and collected, that all those people that are in the UK Biobank had no clinical indication for MRI. And I think that is a real positive thing of the UK Biobank. So listen carefully, because then you understand what kind of people are included in this population. So there are 2,646 subjects enrolled between April and August in 1 year. There were 804 subjects without any known cardiovascular disease. So those patients are the real healthy patients. Then there was a random selection made of 1,842 scans from the remaining 4,261 scans. Those patients were not without any known cardiovascular disease, but those participants were in general healthier, leaner, and with a lower rate of all-cause mortality and lower total cancer incidence than the UK population taken as a whole. So you have to understand that this difference is in this patient selection. They were all studied on a normal clinical 1.5 Tesla scanner using cine imaging. I think the details of that are not very important, but the voxel size is important. It's 1.8 by 1.8 by 6 millimeters. So it means that looking at mitral annular disjunction of 0.5 millimeter doesn't make sense because your voxel size is larger. First, we made a standard operating procedure for analysis of disjunction. Dasa made that SOP, and we checked it, and we studied it on some patients, looked back at it, and we saw, we tested whether that was the way to go to do the measurements on a standardized way and to have the lowest inter-observer variability. And we did that in these 3 imaging planes. And as you can see, you won't have any mitral annular disjunction at the this side, of course, the LVOT side, and you don't have it at the septal side. So you're looking at 4 places, which is the anterolateral part, the anterior part, the inferior part, and the infralateral part. Sorry, this is the infralateral part, and this is the anterolateral part. Disjunction was defined as it was present when it measured 1 millimeter or more. It was measured at end systole, because then you have the largest gap between the mitral annulus and the myocardium. And the 3-chamber view was assessed for the presence of either prolapse or billowing. So that was another thing that we looked at, because we know that there is mitral valve arrhythmic disease. So we also looked whether patients had prolapse or billowing. And billowing was an extension of the mitral valve leaflet above the annular ring of less than 2 millimeters, and we called it prolapse with 2 millimeters or more from the annular plane, as recommended by the American Society of Echocardiography. So again, this is an example of mitral annular disjunction, measured here as 8 millimeters. And then we also looked at curling. And systolic curling happens, I don't have an image, a moving image here, but happens when there is excessive end-systolic motion of the infralateral hinge point of the mural leaflet relative to the ventricular mural summit, and previously related to disjunction in patients with arrhythmic prolapse. So what you can see is that the lateral part of the ventricular wall dances a little bit inwards, while the mitral valve pops outwards to the atrium. Also, we looked at intra-observer and intra-observer variability in 100 randomly selected scans, and that was done by Dasa at one point, and then 1 month interval afterwards for the intra-observer variability, and by another physician, exactly the same 100 scans repeated by the other physician. So clinical diagnosis, including arrhythmic events, were collected from the UK Biobank fields, including self-reported illness, medication use, inpatient diagnosis, and algorithmically derived outcomes. And then we'll go to the results. So of the 2,607 data sets were used because 39 of the participants was discarded due to insufficient quality of any of the long axis views. And if you can't measure any of the long axis views, we deleted the subject for the whole analysis. If we look at the patient data here in this table, I hope you can see this. Then we have the overall cohort, 2,607 patients. We have the strictly healthy cohort, and then you have the subjects with cardiovascular disease or risk factors. Almost half of them are female. The mean age is 61, which is quite old if you compare it with people that die from sudden cardiac arrest. I will come to that back later. And systolic blood pressure is a little bit on the high side. Now, if you look at the number of patients with disjunction, how often it occurs, and the length of this disjunction gap, I'll just go down a little bit because you can't see the numbers of that. So this is for the healthy cohort. You can see that this disjunction present at any site of the 4 sites that I've just mentioned in 80% of the participants. If you look at the participants with cardiovascular disease or risk factors, it's 72%. The majority of the cases have disjunction at the anterior side, almost half of them, or inferior, almost 55 to 61%. And then most important, the infralateral wall on the 3-chamber view, where you also look at billowing or prolapse, it happened or occurred in only 5.1% of the participants. Then if you look at the number of participants that showed prolapse, it was for the whole population only 3%, so that's very low. Predominantly of the posterior leaflet, and there was in 2% of the cases also infralateral curling. So then I'll go a little bit down. If you look at outcome data, we have to say that the number of participants that had events was extremely low. 68 subjects had either reported or had been diagnosed with a cardiac arrhythmia of any kind. And of those patients, or participants, I should say, just 6 were ventricular arrhythmias and 4 people survived a cardiac arrest for any cause before imaging. So for those numbers, it's really, really low. And any additional analysis to look at relation between disjunction or outcome wasn't possible. So as we've seen from the table, that disjunction was found in at least one of the chosen sites in 1990 cases, so that's 76%. So speaking about whether disjunction is normal or not, I think 76% is quite a high number to call it an abnormality. Infralateral disjunction on the other side was found in only 5%. So that was the smallest portion of the participants. And the longest segment was found to be 1 centimeter, and that was on the inferior side. And the longest average disjunction was 3.4 millimeters. So it's not only 1 millimeter, the average is around 3.4. So then we'll go to the relation between disjunction and disease. So we've seen that there was no statistically significant difference between the groups when comparing the length of disjunction between healthy individuals and those with either or at least one risk factor. So there was the smallest healthy group and the larger part of the participants. And with ventricular arrhythmias reported in only 6 individuals, that's what I've just told you, no further analysis could be done. Well, if we look at let's see, the disjunction, the prolapse and the billowing, we've seen that 33 individuals showed billowing, which is outpouching of the mitral valve into the atrium for less than 2 millimeters. And prolapse was found in a bit more participants in 76 individuals. And there was a strong association between the disjunction and a general increased prevalence of prolapse. So if you look at the table 3, it's on the right upper corner. No, sorry. Let's see. Here, so this is the association between prolapse and disjunction. You can see if at the infralateral side there was disjunction present, then in 9.7% of the cases, there was also prolapse of the posterior leaflet. For the other sides, inferior, anterior, anterolateral, the percentages were lower. If you look at billowing, let me see here, billowing of the mural leaflet was also associated with an increased prevalence of disjunction. I can show you in table 4. Sorry for jumping from one table to the other. Here you can see that if there was disjunction in the infralateral wall, I'll just pick up one side, which was most prominently related to billowing or prolapse. You could see that if disjunction was present at the infralateral side, there was a highly likely also prolapse or billowing of the mitral valve in 15% of the cases. So I think I need to move on just a little bit faster here. Then the last thing we studied is systolic curling. So it's the curling of the lateral wall of the myocardium towards the atrium. And systolic curling was found in 51 participants. And of those, 67% had either prolapse or disjunction as well. So you can see that there is, if one of those things happened, they almost, more often occurred at the same time. So the presence of disjunction was associated with systolic curling, and most strongly when infralateral wall had disjunction. And it was also strongly associated with prolapse in general and mural prolapse in particular. So there were odds ratios which was like quite high, as well as billowing. I'll come to that back in the discussion. Just a short note about intra and inter-observer variability. If Dasa did the same thing twice, she did it perfectly, and there was good to accident agreement when another person measured the same measurements. Interclass correlation coefficient of 0.72, which is quite high. So I think in the end, we can conclude from this study that mitral annular disjunction at any site happens quite often in 76% of the cases. In individuals with without either disease of mitral valve or any history of arrhythmia. The second thing we discussed is that the infralateral disjunction happened not that often, only in 5% of the cases. And then we mean the infralateral disjunction, which is closely related to the P2 scallop of the posterior leaflet of the mitral valve. And that is very rare. Then if you relate it to prolapse, systolic curling, or billowing, we could see that both infralateral disjunction and systolic curling of the mural leaflet relative to the basal segment of the infralateral wall have been associated with hypermobility of the atrioventricular junction. And causing that hypermobility and movement of the mitral valve, it's been reported that they've seen in the mitral valve, the papillary muscle or the myocardium, that there was a replacement fibrosis. So they think, other reporters, that the axis force of that mitral valve weakened the myocardium and possibly leads to arrhythmias. One thing that we couldn't see in this study is how that was in this large group of healthy individuals, because they didn't do late gadolinium enhancement in this patient group. So that is a little bit limitation of our paper. Then second, we found a much stronger association of curling with prolapse rather than infralateral disjunction only. So an odds ratio of 72% compared to 12%. So we feel that not the infralateral disjunction itself is causing a problem, but it's the whole thing of the mitral valve prolapse together with the curling and the disjunction at that site. Speaking about the clinical implication of this finding, we believe that disjunction as a sole entity is more common finding in the general population than we previously thought. And we feel that you should not report this in a clinical scan to the referring physician if it's in the anterior, inferior, or anterolateral side. If it happens in the infralateral side, and there's also mitral valve disease and also systolic curling, you might report it. But all the other sides, we've just shown that it's quite common. Then we have a few limitations, really few. And one of the limitations is that the average age of the population is quite high. So you could postulate that all the people that showed mitral disjunction that was related to sudden cardiac death already died. I think that is not really the case, but well, we cannot prove that. And so the patients that we've measured at 61 years of age possibly have a lower risk for sudden cardiac death. Then I'll go to, well, this is the central illustration. I really like this one. This is an image where Dasa showed us the percentages or presence of mitral annular disjunction if there was no disjunction, or 2 millimeters, 3 millimeters, 4 millimeters, and so on, and how often it occurred in a frequency distribution model. Just to show you that the infralateral one really occurs the least, and anterior and inferior mitral annular disjunction happens most often. I think this is where I want to end the presentation of the paper. Dasa, did I miss any important issues of the paper? If so, please tell us.
Absolutely not. I really enjoyed your presentation, and I think you covered everything perfectly.
Okay,
so that's good to hear.
Thank you very much, Robin. And it's always speaks for the research team if the senior author knows as much about the paper than the first author, as the first author. So that's a good sign. And thank you very much, both of you, for providing input. I also enjoyed it a lot. I think it's as I said, sometimes it's very important to answer questions that just linger somewhere with the right data set. And I think and I also agree that the limitations are probably not really hurting the value of the paper significantly at all. So the one question that always comes to my mind when I look at a scan that shows quote unquote annular disjunction is, to what extent is that really a misplacement of the origin of the valve, or is the origin normal? It's just attached to the wall so that in the images, it looks like it would originate here, but in fact, it's here. It's just that it's so close to the wall that we cannot really discriminate it. So that's why I'm particularly interested in your thoughts on the relationship to mitral valve prolapse, which would actually then be something like a little prolapse. And whether you think that is a problem. So in other words, could it be that what we're looking at when we think we see disjunction, that it's just a certain form of mitral valve prolapse where the base of the valve of the cusp is so close to the wall that we think the root is displaced?
Yeah, so I think this is a very important question, and we struggled a lot with that together with Bob Anderson. And Bob Anderson is a pathologist, and he looked at it like very, very many times, and we had huge discussions because he said from the start, it's completely normal. If you look at the hearts, there's a fibrous ring between the mitral annular ring and the myocardium, and it's always there. And when you did echo, you didn't see it. Now you do CT and MR and you see it, but it was always there. And it's no issue, it's just completely normal. So I think that the fibrous tissue that is at the annular site is completely normal. But if you have the mitral valve which prolapse and you have the excessive force of the mitral valve towards the atrium, pulling the papillary muscles, you have the curling, then it's a total different thing. But in my opinion, and I think Dasa should comment on this as well, the annular disjunction doesn't play a huge role in this, except for that the curling can maybe happen even more because otherwise it would have been attached to the mitral annulus more strictly. But I think that the finding is completely anatomically normal. But Dasa, maybe you can comment on this as well, because you had even more discussions with Bob.
Yes, please. Matthias, first of all, thank you for this absolutely excellent question. I'm not gonna go from the point of discussions we've had with Bob, but rather from the clinical setting, because as of now, I'm the person a lot of people consult regarding the mitral valve, regarding whether or not there is a mitral annular disjunction. And I'm also, obviously, I've seen so many data sets by now that I do understand the question or the doubt that was in Matthias's mind when asking this question. I think most of the times, if we observe the mitral valve carefully during the whole cardiac cycle, both in CMR and in echo, you can distinguish whether or not there is a tiny prolapse at the base of the leaflet or whether or not it's actual MAD. And what I've found when discussing this with my senior physician friends in our setting, because I work in cardiac surgery, so we see a lot of mitral valves that need repair or replacement, is that a lot of times people will call something MAD, the disjunction, when it's actually just a prolapse, but not the other way around. So usually people will overcall disjunction, even when there is just a tiny little prolapse. But if you are in doubt, just going through the cardiac cycle, even the temporal resolution of CMR is more than good enough to just follow the leaflet. And if you follow it through the cardiac cycle, you will see whether it attaches at the myocardium site or it attaches a bit more atrially. And that's the distinction that helps. That's the area where you can really distinguish this disjunction and prolapse. So in my opinion, if you're in doubt and if you recheck, just run the image again, whether on echo or on CMR, I think in 98% of cases, you will be absolutely certain whether or not you're seeing disjunction or a little prolapse.
Thank you very much for the clarification. That's exactly what I'm trying to do then, that I go image by image to see, is there one where I think I see the origin and is it close enough? Yeah. Then a question related to that, actually, from Dana Peters. And she is asking about ideas to improve the visibility of valve leaflets in CMR, whether you have any ideas. You must have thought about that both a lot. And maybe a question as well, is an increased temporal resolution maybe an option?
Well, as everything, I mean, obviously, I think Robin, because he has so much more experience, will be able to answer this question better. But in my experience, nothing in life is for free. And if we increase the temporal resolution, we'll lose the spatial. And I think where we are right now, I think this is good enough to distinguish disjunction from prolapse. And I think in this case, for this particular issue, perfection would be the enemy of good. but maybe Robin, you can answer this.
No, I agree totally. The only thing is that I see that for, some sites have in-plane resolutions, 1 centimeter thick slices. And if you go for 1 centimeter thick slices, it is less easy to look at the valves specifically. And also if you have valve problems, for example, where there is a stenosis or extensive regurgitation, you need sometimes to use a spoiled gradient echo to have a better view on the valves, which also helps. But I think the most important is to not to increase your slice thickness that much.
Yeah. Okay. So as I often see in life, that problems sometimes are a blessing in disguise. So we're already running over time, although we just discussed this paper. That basically is an indicator that it is important and that it was good that we had the time. Now there's one question, and then I will have a short one. Then we'll have to wrap it up from Corey Tranquil. I don't know, Corey, whether you want to just unmute yourself and ask the question yourself. Otherwise, I can read it, but feel free.
Hi, sure. Sorry, really wonderful presentation and paper, and thank you so much for bringing this forward. We've had a few cases that have the mitral valve prolapse and basal systolic tugging effect, but it's always kind of lingered that cause versus effect question. And in some of these cases, we've seen an anomalous papillary muscle insertion to the base of the LV, and it seems like it's sort of tugging the base of the heart downward towards the apex, and maybe could be the cause of all this. Did you see this? Did you look at papillary anomalies, or have you noticed this in any of your unselected or selected cohorts with arrhythmias?
I think this is a very good question. I didn't look at papillary muscles specifically. Dasa, have you noticed any papillary muscle abnormal insertions, or is that, I think that was not the case, but I'm not sure.
Yeah, so if you look at papillary muscles very carefully, you'll learn that there's so much variation in the general population. It's usually not just 2 solid muscles that all of the chordae attach to. So oftentimes it's just going to be split at the end, or obviously all of you know this. So I haven't noticed that it would be anything extremely special in this biobank population, but obviously, as Robin has pointed out, the curling effect was only present in 51 people, and I think 12% out of those had neither prolapse nor disjunction. So it's not as pathognomonic as we thought it was. And I think there's there are other forces at play that cause this strange movement. But obviously, if you see this tugging the way you described, Corey, I think that's something that I think could be correlated with then late gadolinium enhancement and other things that other researchers have described. So our paper is just trying to add on knowledge, not disprove whatever's been published so far.
Yeah.
Okay, thank you. So I have a very final one. I try to make it short. Would you feel comfortable saying that even if we would use very strict criteria, because clearly more than 70%, you cannot just create a disease from that, and you made that very clear. But if we would use very strict criteria, say something like more than 5 millimeters inferolateral, is it fair to say that even if we would use such criteria, we currently do not have evidence that this has any, let's say, clinical relevance? Or do you think we need more research on very strict definitions of a disjunction, if it exists?
Well, I think it is important to have guidelines to know what's abnormal and normal, but Dasa even found an inferior mitral annular disjunction of 1 centimeter, and that was it. There was no mitral valve disease in that patient whatsoever. So I think we do need to focus on not just one single measurement, but the whole patient with the mitral valve as well, and in the infralateral part. And I think if you see that over there, and if there's also, for example, late GAD or curling, you might consider a follow-up scan, for example, after 3 years or something. But if it just happens to be there, the anterior or inferior side, leave it alone.
Yeah. Thank you so much. I really enjoyed the fantastic presentations and discussion. There are actually more questions. So from Sabrina, Rebecca, and Martina, is it okay if I ask you to just send them by email to Robin and Dasa?
Sure.
They will get on that, because I don't want to get stress, let's say, everybody's time too much. Before we leave, so Robin, if you could unshare your screen, then I would like to hand over to Nicole, the co-host here, and Nicole will talk about the next CMR Journal Club.
All right, hopefully you can hear me and see my screen at the same time. Perfect. Okay. So thanks, Matthias. So as we said before, our next CMR Journal Club meeting will be on May 31st at the usual time. And in this Journal Club, we're going to look at a couple of different methods for accelerating diffusion tensor cardiac MRI. So there's going to be a presentation by Dr. Pedro Ferreira on accelerated cardiac diffusion tensor imaging with a UNET-based model towards single breath holds. And then also by Dr. Yanjie Zhu on slice-specific tracking for free-breathing diffusion tensor cardiac MRI. So please join us in 4 weeks again.
Thank you very much, Nicole. And again, thank you, Robin and Dasa, for the wonderful presentation and for this great discussion. I think we all learned a lot, and this is clinically relevant, so that makes a difference. Take care, everybody.
Thanks
and
a
have
lot.
a good day. See you next time.